Now started recording.
Jamie, under which portion of the...
All right, here we go.
Is it under the SJ?
Shh, we're about to start. All right. The pen will come up again, so don't worry too much about that. All right, which of the following is able to affect both blood pressure and heart rate from the level of the CNS? Is it clonidine? Is it felodipine, verapamil, or minoxidil? What else do we use minoxidil for? Hair growth, absolutely. Hypertrichosis. Okay, so let's look at this. So looking at our different options here. So felodipine is what type of drug? What type of calcium channel blocker is felodipine? Dihydropyridine, right? So amlodipine, nifedipine, the PINE, it kind of gives you a clue. It's probably one of those dihydropyridine calcium channel blockers, right? So again, any kind of port in a storm, any kind of thing we can use to try to categorize these by name can be very useful for memorization purposes, right? Verapamil is what type of drug? Non-DHP, right? And then minoxidil is what? Think about how you're trying to cause that hair growth. You're trying to increase the blood flow to the head, so you're dilating those vessels, right? It's an alpha blocker essentially, or not alpha. I'm sorry, not alpha blocker. It's a vasodilator, though. It's an arterial dilator. Same effects essentially. You're getting that direct arterial dilating sort of effect there. That's how you're getting that. More nutrients going to the head, maybe more hair growth going on, or wherever you're applying it. Clonidine, however, is working where? In the CNS. I'm sorry. Yeah, so it's working the alpha-2 receptors. Remember, by activating the alpha-2, you're decreasing that sympathetic outflow. So again, this is working from the CNS down to decrease both blood pressure and heart rate because you're releasing less norepinephrine, right? Now, which one of these could also decrease heart rate and blood pressure? Verapamil could, the non-dihydropyridine, because again, different mechanism, but it's working directly on the heart and the vessels to decrease heart rate, decrease blood pressure. Now, on the flip side, what would felodipine and minoxidil do you think? They would lower blood pressure for sure because they both are vasodilators to a degree, different mechanisms still. But what would they? Increase heart rate. Yeah, it's certainly orthostatic hypotension you expect to see, but definitely reflex tachycardia is what you could see in that case. Okay, so again, have an effect or have an idea which effect the drugs are going to have as far as heart rate goes, as far as blood pressure goes. Again, any rebound effects, you need to be able to suss those out. Okay. Up next. A potential side effect from the use of evolucumab, Repatha, is it anaphylaxis? Is it infection? Is it undetectable LDL or rhabdomyolysis? All right. So actually, there were two correct answers I included on this. One of them I didn't really talk about in class, but it's kind of an interesting side effect here. So what do you notice about the drug name? It's a monoclonal antibody, right? Anytime you're injecting a monoclonal antibody, there is a risk for anaphylaxis because, again, these are big molecules compared to a typical drug you'd see. This is a big protein. So, again, anaphylaxis is always going to be a risk, right? What was this drug used for? Yeah, it's lipid lower. Remember, it prevented that recycling of those LDL receptors. It kept more of them on the surface of the hepatocyte, so you scavenge more LDL from the bloodstream. So actually, an interesting, unique side effect of that is actually in some patients, they developed an undetectable LDL. It was so effective at lowering LDL that they couldn't even measure it in the bloodstream anymore, right? Again, they don't know if there's any kind of negative consequences to that, but it was something that they noted in clinical trials. So it's kind of a unique side effect there. Now, infection, This is a big thing you have to worry about with a lot of other monoclonal antibodies, but these are going to be more specific to ones that are like anti-inflammatory or ones that are going to suppress the immune system. We'll come across a lot of those when we get to the rheumatology section a little bit later on, probably in Pharm 2 if I had to guess. Rhabdomyolysis, what drugs can cause that? Statins, right? Specifically, the dose is too high, or if you have, say, an inhibitor of metabolism on board, plus one of those statins there, right? What are the 3 big statins that get affected by 3A4? Simvastatin's a big one. Atorvastatin, and forgive you didn't know the last one. Lovastatin's another big one, right? So lovastatin, atorva, and simvastatin. Atorvastatin, simvastatin are probably the 2 more common ones out of that group you're going to run into, but a lot of patients are still on those drugs, so you have to watch out for those interactions, right? Which one kind of avoided all those interactions? Rosuvastatin or Crestor, right? So that one's that's the most potent one you have, and it doesn't have those CYP interactions. So a lot of patients, if they can tolerate that, if they can benefit, if they can pay for it, that's a really good one for them to be on. Okay. Which beta blocker would be best for a patient with poorly controlled asthma? I'm sorry, atenolol, propranolol, sotalol, or pendolol? I should have heard that answer. I was lost in thought for a second there.
Yeah, I think I know it. But I was too quick for that. I was waiting.
Very good. Right. So remember, what are we looking for in this question? Looking for the cardioselective beta blocker, right? So we're looking for one that predominantly tries to hit the beta 1 receptors without affecting beta 2, right? Because what happens if I block beta 2 receptors in an asthmatic patient? You can see bronchospasm, bronchoconstriction occur that can induce an asthma attack. So this is one I would want to avoid. So again, how do you remember which ones are cardioselective? A through M. Remember, you have to remember the exceptions, right? The carvedilol, the labetalol, cardiolol, things like that. But A through M typically are going to be your cardioselective beta blockers. So it means atenolol, metoprolol. What else? Anything else? Those are the 2 big ones you're going to run across, I think, most commonly. Those ones I always think of, at least I have to go back and look at the list again. But like betaxolol is another good one, kind of fit in that category. But it happens to be beta 1 selective. The other ones, though, N through Z, like your nadolol, propranolol, pendolol, any of those tend to be non-cardioselective in those cases. Sotalol is kind of a unique one. This actual one we'll talk about more in the antiarrhythmic section. This one frequently is not used for blood pressure control, but more for arrhythmias. So we'll mention that a little bit later on in this course. If you have any questions, just go ahead and feel free to raise your hand. We'll talk about them as they come up. A patient develops rhabdomyolysis after taking simvastatin and what other medication? Verapamil, lisinopril, evolucumab, or ezetimibe? That was almost a completely even split. That was pretty good. Okay, so looking at this, thinking, okay, which one of these is going to help to increase levels of simvastatin, right? So there's a couple ways you could do that. You can inhibit CYP3A4. You can inhibit that PGP protein, right? That efflux pump. Those are the main ways you can do that, right? So the question is, well, which one of these was going to be a CYP3A4 inhibitor, right? There's actually another mechanism, actually one that I didn't really spend too much time talking about, but also like gemfibrozil, one of the fibrates, can actually raise up your simvastatin levels as well pretty significantly. But again, this one was mainly focusing on the 3A4 aspect of things, right? So verapamil, as we remember, we kind of said earlier, inhibits CYP3A4, right? So again, that would be the correct answer in this case. I could have alternatively put diltiazem on here as well, right? So be careful with that, right? What if I'd put rifampin on here? You guys remember we talked about that briefly? Endocarditis? What would that do?
It's a RNA polymerase inhibitor.
That's true, but what does it do to your CYP enzymes? Right, that one's unique because it was actually a CYP3A4 inducer. So that was one of those kind of rare exceptions with that. That would actually lower your levels of simvastatin. If a patient was on those two, you'd actually end up seeing the LDLs probably would climb in that case because you have less drug around. But so that's not the case. Lisinopril, no drug interactions from a CYP enzyme standpoint, which is great. Evolucumab, that's only because it's one of those antibodies. It's very specific for attacking that PCSK9 enzyme. Really has no effect on anything else in the body, which is nice because it's very targeted, very specific for affecting that. And then ezetimibe, we put that combination together all the time. If you ever see like Vytorin, it's usually a simvastatin plus ezetimibe combination, so that one's pretty safe to give. Okay. All right. Which of the following diuretics would exacerbate hyperkalemia? Would be acetazolamide, bumetanide, metolazone, or spironolactone? I like it when people get words mixed up, and so exacerbate and exasperated are two of my favorite ones. Because someone will come up and say, I am totally exacerbated right now. And you're exasperated with my when I'm talking to you or whatever. Very good, very good. Yes. Because you could also call spironolactone what? Yeah, you can call it a potassium-sparing diuretic because it's going to actually hold on to more potassium. So that's actually correct in that case. Now, acetazolamide is what kind of diuretic? Carbonic anhydrase inhibitor. Remember that we talked about some of the ophthalmology stuff too. We had brinzolamide, dorzolamide. Those are all carbonic anhydrase inhibitors. Those actually lead to more potassium release, right? Bumetanide. What type of diuretic? The loop. You absolutely lose potassium with that one because that's actually inhibiting that sodium chloride and potassium transporter in which part of the kidney?
Ascending loop.
The loop of Henle, right? So the ascending loop is what's loop diuretic, right? Metolazone is what kind of diuretic? Is a thiazide diuretic. Don't forget that one because what did I say was unique about that one? Can make a rock pee, right? We remember that loop diuretics, they retain activity. See, some of these things I have to say it in a funny way because that helps to stick in your mind for longer, right? But the loop diuretics, you can use those despite whatever the patient's renal function actually is. They tend to retain activity, increasing urine output. Thiazide diuretics will lose that activity as renal function decreases, right? So again, if I said which one of these diuretics would be appropriate for a patient with poor kidney function, I would say like creatinine clearance, I'll say 10 mLs per minute. And I had a list of all the thiazide diuretics. Metolazone would be the correct answer in this case because it actually still retains activity even below, say, 30 mLs a minute. Okay, so again, what's a normal creatinine clearance? Closer to 100, right? So again, creatinine clearance at 30, pretty well diminished. Creatinine clearance at 10, you can definitely see patients like that, is very well diminished. You need to make sure you're using the right kind of diuretics for those patients, okay? So metolazone would be correct in that case to give it to someone with really poor kidney function. But then spironolactone, again, and thiazides, we know we're going to lose potassium as well. All of them are going to, except for the potassium-sparing diuretics, okay? What other potassium-sparing diuretics do we have? Triamterene, amiloride. What was the other aldosterone antagonist? Yeah, pleuronone or Inspro is the other one, right? So spironolactone and pleuronone, think of those two together because those are both aldosterone antagonists, right? Very good. Up next, which med could cause acute decrease in GFR in a patient with chronic kidney disease? You have clonidine, prazosin, lisinopril, or hydralazine. Does an acute decrease in GFR, patient with chronic kidney disease. All right, so let's look at this. Now, could you maybe say, well, if I drop the blood pressure enough, and don't use this slide to argue a question on the test on Monday, please. But you say, well, if you lower the pressure enough, I mean, then you're definitely not perfusing the kidneys, and that could cause a decrease in GFR. Yes, but we're talking kind of therapeutic doses here. We're not talking about an overdose. But clonidine would not do this because, again, it's just going to decrease norepinephrine output. You're going to find that, remember, what does norepinephrine do to the afferent arteriole? Usually constricts it, right? Because again, that's one of those things where norepi, remember when the body's in the sympathetic state, it doesn't want to send blood to the kidneys necessarily, it wants to go to the heart and the head. So it'll release norepi to actually squeeze down on that and cause a decrease in GFR. If anything, clonidine may actually help a little bit. A little bit. Prazosin's what kind of drug? It's an alpha blocker, yep, absolutely. So you're going to find that's going to dilate the vessels, no real effect on on GFR. Hydralazine is what kind of drug? It's going to be another arterial dilator. Again, should be acting very similar to prazosin. Really shouldn't see any effects there. Now, does anyone know what drug you commonly see getting mixed up with hydralazine? No, as far as like name go, hydrochlorothiazide. Maybe I could see that. I could potentially see that. What'd you say?
I mix it up on like every single test. So.
Oh yeah, you don't want to do that. I'd recommend against that. Actually, another really good one is hydroxyzine. Remember, hydroxyzine is what kind of drug? That was one of those antihistamine, the first generation antihistamine we talked about back all the way in ENT stuff, right? So again, that's one of those things where the hydroxyzine, hydralazine get mixed up very commonly. And again, if I gave a patient who needed hydroxyzine for allergies and I gave him hydralazine, what's going to happen to him? It's probably going to be hypotensive, right? So it may not be a good thing. That's one of those common medication errors. That's why if you ever see like tall man lettering, which means like the middle part of a drug name will be in capital letters, that's what that's doing, is basically to try to prevent mix-ups. So you see oxyzine, hydroxyzine, you're thinking, okay, that's going to be antihistamine versus hydralazine. That's going to be cluing you in. That's for the blood pressure management. But again, lisinopril, how is that going to affect GFR?
So I won't be going to get like efferent arterial.
Exactly. So you're decreasing Ang2 production. Ang2 normally does what to the efferent arteriole? Constricts it. No, if I get rid of that, it's going to cause it to dilate. That relieves that pressure on the glomerulus. So with a patient with chronic kidney disease who really needed that GFR or that Ang2 around to keep that pressure up, now it's gone. You can have an acute decrease in GFR there. Normal healthy individuals don't have that problem. They have enough reserve where they can still meet the needs of the glomerulus. But chronic kidney disease, they need that pressure there. They've probably been building that up for a long period of time to need that. Now, does that mean you cannot give those patients an ACE inhibitor? No, they probably need to be on an ACE inhibitor, if anything, because it helps to kind of preserve some of those function there. But it just means you need to start a very low dose and gently titrate up, right? Do you have a question?
Yeah, I was just going to ask about ACE inhibitors for the vertical hypertensive kidney.
Yeah, exactly, because it's going to help to preserve that function. Because again, if I can relieve some of that pressure, again, slowly over time, if I can kind of get the kidneys used to that, you're going to find that relieving some of that pressure kind of helps to preserve the glomerulus for longer, kind of helps to keep it functioning well. And again, it doesn't fix the problem. It doesn't turn back time and make their kidneys work better, but it will help to hopefully slow down that progression as you go along. So diabetics, chronic kidney disease, ACE inhibitors, and ARBs are going to be really good options for them. But be careful. To have kidney disease, start at a low dose and titrate up. Don't give them just full court press right from the bat. Okay, those are too many sports references, and I'm not very well versed enough to make those. But that was a real slam dunk. Okay, which antilipemic would be best for a pregnant patient? I have ezetimibe, rosuvastatin, cholesterol, or gemfibrozil. Metoprolol would not be a good antilipemic. And the quicker you answer, the sooner I get to the answers and go through it, so otherwise I'm worried about running over. So just go with your gut. All right, so what am I looking for here as far as like drugs for pregnant patients? If it doesn't get absorbed, the better it's going to, or not the better it's going to work, but the better it's going to be for them because, again, less systemic effects are going to be seen there. So that's why something like a bile acid sequestrant would be correct in this case. If it doesn't get absorbed, it's going to be the drug of choice in those cases. Now, ideally, what would I like to do before that? Dietary modification, exercise, whatever's going to be appropriate for that patient, but they still needed something. A bile acid sequestrant would be good in that case. So it could have said cholecalciferol, could have said cholestyramine, any of those would have been fine. But remember that a lot of these other meds are going to be contraindicated in pregnancy, especially the statins. Those are no good. You need to have that LDL. You need to be able to produce things like hormones. You need to be able to produce things like cell membranes, and then you need that cholesterol there. So the statins are going to be contraindicated for pregnant patients for sure. All right. Which of the following can cause bradycardia in patients with significant nasolacrimal drainage? So switching over to the eye stuff. Bromonidine, latanoprost, tetracaine, or cardiolol? All right. So what am I looking for here? Beta blocker, right? Because we talked about having that nasolacrimal drainage. You can see systemic absorption. Beta blocker is going to be the culprit here, right? How does latanoprost work? Think prost, think prostaglandin. Really shouldn't have any cardiac effects, right? That's why we like that one for a lot of patients as first line. It's great. Tetracaine does what? It's a numbing agent, right? So again, it's blocking sodium channels. We really shouldn't see any systemic effects from that drug. How about bromonidine? What is that? It's actually similar to antihypertensive we talked about. Yeah, it's alpha-2 agonist, but clonidine is a big thing there. So clonidine is good. Bromonidine is going to be good as an alpha-2 agonist. Now, typically, this one is, as I mentioned, is pretty highly ionized, so it has a hard time crossing the blood-brain barrier. So you don't really see as much from a systemic standpoint as you would expect to see from like a clonidine, which can cross pretty easily there. So cardiolol would be the correct answer in this case. Okay, Pataxolol would have been another decent one. Any of the beta blockers was fine here.
You said not to use them under the age of 2, right?
Yeah, the alpha-2 agonists you do not want to use under 2 because then you would be really worried about it getting absorbed across the blood-brain barrier, seeing hypotension, bradycardia associated with that, right? So again, that would be more patient-specific than just in general patient, right? Good. All right. Which of the following medications would worsen LV function in a patient with CHF? Be ramipril, verapamil, carvedilol, or amlodipine. These will worsen left ventricular function. And again, we haven't covered CHF specifically yet, but we've talked about these mechanisms, so you should be able to suss this out, right? All right, so there's actually 2 correct answers here. Again, I'll only give you 1 correct answer on the test, but this is trying to challenge your noodle a little bit there. So, ramipril, what's that going to do for us? It's an ACE inhibitor, so that means it's going to cause decrease in TPR. It's going to decrease angiotensin II production. What effect should it have on the heart? Nothing directly, right? It's not going to be, you don't even see that reflex tachycardia like you do with like a real direct vasodilator like you see with like amlodipine or something. So no big effects there. If anything, what does it do for the LV function? Doesn't increase it necessarily, we can preserve it over time, right, by decreasing that remodeling that occurs. So again, a lot of patients with LV dysfunction should be on an ACE inhibitor due to the fact it can help with kind of preserving that function over time. Okay. Now amlodipine, what would that do to LV function? Really, so it's a DHP, a dihydropyridine calcium channel blocker. So if anything, it would have neutral effect, shouldn't really do much, or if anything, you may see kind of an uptick in contractility to try to have that reflex response, but really shouldn't see a whole lot from that standpoint. We shouldn't see a worsening, if anything. Okay. Now on the flip side, though, we have verapamil, which is what kind of drug? The non-dihydropyridine, so we know it's going to be working directly on the nodal tissue, working on contractility, no good, right? How about carvedilol? It's a beta blocker, right? We know beta blockers can be problematic too. Now, again, with someone with LV dysfunction with CHF, carvedilol is going to be a preferred drug. That's something they definitely need to be on from a mortality standpoint, but you got to start very low dose and titrate up. Okay, just like we talked about before. Seems counterintuitive to put someone with LV dysfunction on a beta blocker, but the studies have shown, thousands of people say that, hey, mortalities are going to be improved in these cases. Okay. All right. Which medication would be recommended in a patient with isolated hypertriglyceridemia? We have ezetimibe, fenofibrate, cholestyramine, or atorvastatin. All right, so looking at this, now ezetimibe and atorvastatin should have pretty balanced effect between the two, right? So ezetimibe does what? Yeah. Yeah, blocks cholesterol absorption from the GI tract, right? So that's going to have good effects on lowering LDL, have some okay effects on lowering triglycerides. So that would be okay to use. It wouldn't be wrong to use in this case here, but again, it doesn't treat the main problem they have, which is specifically their triglycerides being high here, right? There's some genetic conditions where you can see that. Atorvastatin, which we know is a statin, is going to do the same thing there. It's going to be more potent than ezetimibe, but will do the same thing. Cholestyramine being what kind of drug? Bile acid sequestrant. Which means you're going to bind that stuff up and then you're just going to poop it right out. What does that do for your triglycerides? Actually increases it, right? So this would exacerbate a hypertriglyceridemia. That would not be recommended. On the flip side, though, you have fenofibrate, which is what kind of drug? A fibrate, good. So like gemfibrozil, visafibrate would be fine here as well. That should help with not only getting the triglycerides down, what else can they do? Raise the HDL, right? Good. So if you needed some HDL bumping, this would be a good drug. Alternatively, what could I have used? Niacin could have been used as well, right? And we like extended release niacin and limits a lot of those flushing side effects, right? Good. Which medication can mitigate the unique side effect of immediate release niacin? It's a good lead-in. Would you use acetaminophen, torsemide, aspirin, or hydralazine? This is actually very pertinent based on
Friends.
Friends?
Friends that took a bunch of nights.
Oh yeah, my friends definitely took too much of it. It was very miserable for them. I still ask them every once in a while, you remember that time? They're like, yes, I remember that time. The wave of nausea comes back over them. Yeah, so aspirin could be used here. Alternatively, what could we have used? Ibuprofen? Naproxen would be fine. Yeah, aspirin has just been used classically. I think it's probably just because it's been around the longest. But again, what are we trying to do here? We're trying to prevent that flushing. Preventing prostaglandin synthesis, right? That's why typically prostaglandins tend to be vasodilatory. That's why you see that flushing that occurs with that. So aspirin would be very good. Tylenol would not do that, right? It's not going to be a prostaglandin synthesis inhibitor. That's why it's not an anti-inflammatory, right? So it's a good distinction to make there. You're noting that. What's torsemide? A lot like bumetanide, a lot like ethacrenic acid, a lot like furosemide,
Yeah.
loop diuretic, right? It's not just enough to know it's a diuretic. You want to know it's a loop diuretic in those cases, right? Furosemide, bumetanide, torsemide, ethacrenic acid. Those are all your loop diuretics. And hydralazine we mentioned is what? It's a vasodilator, right? So it's good for just acutely decreasing the arterial pressure there. Good. A patient with chronic constipation should avoid which medication? Bumetanide, ramipril, prazosin, or diltiazem. What do we think?
Are you sure it's doing
All right, so remember that for peristalsis to occur, that smooth muscle needs to contract. What do I need for that to occur?
Calcium.
Calcium, right? So I need calcium to be influxing through those cells. What is blocking calcium? Calcium channel blockers, such as diltiazem, right? So again, that would be one that can cause constipation. I could have put verapamil there. Could have put amlodipine there. Any of those can exacerbate constipation in the patient, right? Bumetanide, we mentioned, is a loop diuretic. Shouldn't really cause any effects there. Prazosin, alpha blocker, shouldn't cause any effects there. Ramipril, ACE inhibitor, shouldn't really cause any effects there as well, right? So calcium channel blockers specifically cause a lot of constipation, right? And again, it's not uncommon to have a patient with, say, chronic pain issues. They may be on opioids or stopping up their bowels as well. Add this on, it could be exacerbated by that, right? So again, be careful when you have multiple meds on board. Even something like a heart med, you wouldn't think causing constipation, but if you think to the mechanism, you can see why, okay? Which of the following would be most likely to cause bradycardia? Nifedipine, terazosin, irbesartan, or diltiazem?
Tans, yeah.
All right, so looking at this, what do we think, right? We've been talking about these all the time. Right? It should be pretty clear, right? Based on the angina talk we had, right? Which drugs are going to decrease heart rate? Which ones specifically? Which calcium channel blockers? Non-DHPs. So non-DHPs are going to be good for decreasing heart rate, can cause bradycardia. What else could I put there? Beta blocker, right? Those are two big groups we've already talked about as being negative inotropes, negative chronotropes. Okay, so be able to identify those. Nifedipine and terazosin would have caused most likely what? Well, yeah, they cause vasodilation, and then as a reflex, tachycardia, right? So again, you expect to see tachycardia associated with those drugs. If anything, irbesartan, which is what kind of drug? It's an ARB, an angiotensin II receptor blocker, should cause. You'll see vasodilation, right, because you're losing that Ang2 effect, but you really shouldn't see many changes in heart rate, right, which is good. That's very heart rate neutral for those patients. Good. Mydriasis could be caused by which medication? Fluorescein, trypan blue, cyclopentolate, or carbachol? I can't remember if I took out the trypan blue off the slides or not. I might have. So you have no idea what that is, so it's probably not the right answer. There you go. The other three, though, are definitely there. Trypan blue is a dye you can sometimes use for vitrectomies. I've seen moving.
And for cell counting. And for cell counting.
Oh, sure, yeah. There's other uses for dyes as well. So there you go. Trypan blue for cell counting. I did not know that. Don't ever spill that stuff on yourself. It stains like a mother. So. Actually, my mother-in-law does a lot of staining for clothes. She likes to make clothes for my children, so she actually does stain like a mother does. All right, yeah, cyclopentolate. Cyclopentolate, how does it work? Cause Mydriasis, but how does it do that? There's two ways we can do that, right? So we can either antagonize something or we can agonize something. Antagonize, I can antagonize the... Right, so if you're thinking parasympathetic, you're thinking antagonizing the... Which type of receptor? Muscarinic, right? So remember, blind as a bat, right? That's part of that mnemonic for anti-muscarinic. So if you see Mydriasis, we have an anti-muscarinic on there. Alternatively, I could agonize which receptors? Adrenergic receptors. Remember, phenylephrine was a drug that we could use on the pupils as well to try to dilate them. Okay, so either one could work. And what's that term for causing something that's going to try to impair pupillary constriction? Called cycloplegic, right? So again, you're trying to inhibit that from occurring so that we can get a good exam, or you're doing surgery, or whatever the case may be. Fluorescein we use for staining, right? So again, it shouldn't really cause any changes in pupillary constriction. The carbachol. If anything, that's actually a cholinergic agonist, muscarinic agonist. That would actually cause meiosis to occur, right? And again, why don't we like those as like meds for glaucoma? Not painful necessarily. They're very difficult to see, right? They're going to affect your accommodation. It's going to impair vision for your patients, as opposed to like a prostaglandin or a beta blocker. You don't really see that. So again, very much not preferred for glaucoma patients. Use carbachol. Which medication could cause iris discoloration? Maybe if you spilled trypan blue on iris out there, that would cause discoloration, but we're speaking about the ocular iris. So we have tafloprost, we have dorzolamide, pilocarpine, or levobunolol. All right, so what do you notice about the name of that drug? Prost, it's got a prost name, so that means it's going to be a prostaglandin. Remember, what do we like to use for our Latisse? Bimatoprost, right? We like to use prostaglandins for that. Helps there increase the eyelash length, but also darkens the iris color as well, right? So again, those are two big side effects, that we sometimes use for aesthetic effects, as the case may be. So that's one thing. Dorzolamide is what kind of drug? Just like acetazolamide and brinzolamide, carbonic anhydrase inhibitor. Yeah, so again, carbonic anhydrase inhibitors. Pilocarpine, remember what that is? It's another cholinergic, just like carbachol was. Good, so that would not cause that. And then levobunolol. It's a beta blocker. Yeah, you can just tell based on that, right? So again, this could cause bradycardia. Probably not going to change the iris color at all. All right. Sudden withdrawal of which medication can lead to severe rebound hypertension? Irbesartan, nadolol, amlodipine, or clonidine? Very good, very good. There are two right answers here, actually. So, yeah, so let's look at this. So remember, irbesartan is good. It actually doesn't have any rebound effects, so to speak, so that's good. Similarly, any of the ACE inhibitors would not do that either, which is good. Amlodipine, additionally, is blocking calcium influx, but it doesn't really cause a lot of shifting as far as the upregulation or downregulation of receptors there. However, the two big ones, beta blockers, cause upregulation of beta receptors as you're blocking them. cause rebound hypertension. You got to wean them off of that. Clonidine can do the same thing as well. So again, you have to wean them off of these drugs if they've been on them for a while. Otherwise, you're going to see a rebound hypertension. Not going to be good, right? You can induce things like MI potentially, induce stroke in some patients. You're really, really careful, okay? Which anticoagulant works on the works with antithrombin 3 to inactivate factors 2, 10, 11, 9, 11, and 12? We have warfarin, fondaparinux, heparin, or enoxaparin. Let's move back into the anticoagulants. Again, if you answer quickly, I have 11 minutes. I would greatly appreciate it, just for your sakes. I can go over. I can talk all day. Actually, technically, I have till 4:30. So if you guys want to stick around, okay, I didn't think so. We can do group watching of my EpiBio videos. I'm like, oh yeah, remember that slide? That's a good one. All right, yes, heparin would be correct there, right? Remember, heparin is a big, long sugar molecule. It's able to work with antithrombin 3 and activate several different factors. What are the two clinically most important ones? 2 and 10, why?
Because that's part of the common pathway.
That's the common pathway, basically, right? 2 and 10 are two of the biggest ones in the common pathway. They feed back quite a bit to help increase that positive feedback loop in those cases there. So if I can interrupt that, that's going to get the most bang for my buck, right? In this case, warfarin works primarily on what? 2, 7, 9, and 10. Those are mainly produced in the liver, so you see a little bit different effects there. Fondaparinux works only on what? Has an X in it, so you want to think X? 10, right? So that's going to be specifically a 10A inhibitor. So that would not be the case. And then enoxaparin, mainly 2 and 10, right? If it was just 2, it would be called a direct thrombin inhibitor. We have drugs that do that, but that's not the case. Remember, enoxaparin is considered what? A low molecular weight heparin. So once you chop up that heparin, you get smaller pieces. You're not able to interact as well with both 2 and 10. You end up getting a little bit more preference for 10, right? So again, enoxaparin works better on 10 than 2, but still retains some activity. When you shorten it up even further, fondaparinux is just 5 sugar molecules long. It's going to just work on factor 10. Okay, can I get an idea which factors these are working on? And again, what monitoring is going to be important here. We'll talk about that in a second as well. Which of the following drugs can cause CYP3A4 induction? I already gave this one away. See if you remember. Parazenamide. Actually, this should have been in a different. This should have been the Pharm section. So you're not even familiar with 3 of these drugs yet. That's okay. I forgot to remove it. But parazenamide, ethambutol, isoniazid, rifampin. Which one do you think is a CYP3A4 inducer? I also want a freebie for the game that actually has no bearing on your education at all, or at least your scores. Should bear on your education. Yes, rifampin is actually the one there. Where do we use rifampin at? Well, what do we use it? Where do we already cover it being used for? Endocarditis, right? Remember that was the last one we added on because the resistance was an issue. But yeah, this is the 4-drug combination used for active treatment of TB. Again, it's used 4 drugs because mycoplasma or tuberculosis is going to be very, very difficult to treat due to the slow-growing sort of nature of the disease. Anyway. Which antidote in drug combination is correct? Phytonadione or vitamin K plus enoxaparin, fresh frozen plasma plus aspirin, adurosizumab plus rivaroxaban, or protamine sulfate and heparin? So if your patient overdose on this, which one needs to be the correct antidote to give them to reverse the effects? All right, let's look at this. All right, so vitamin K is the antidote to which drug? Warfarin, right? Warfarin, because remember, that's a vitamin K antagonist. So if I can give them more vitamin K, I can bypass the effect of warfarin and I can start to produce new clotting factors. Now, is that an immediate acting drug? No, I still have to produce a clotting factor, so it may take a couple hours, days before you see the full effects of it, but you're still going to give it pretty early on if you have a patient who's bleeding with warfarin, right? FFP, that would be good to give for someone with warfarin overdose, right? Because again, that is repleting the patient with factors that they have not been able to produce due to that warfarin, right? Now, if I gave something like fresh frozen plasma, which has all my clotting factors, to a patient who maybe had too much enoxaparin, would that work? Not as well, because what you're going to find is that enoxaparin is going to start to work with that antithrombin 3 to start to deactivate your 10 and your 2, right? Predominantly your 10, though. So again, that's not going to be as effective because of that. So that would not be the correct case here. Is there a reversal for aspirin? I wish there was, but there's not. Once the effects are there, again, it's a non-reversible inhibitor, especially cyclooxygenase in the platelets. It's there, right? You can't really do much about that. Now, how about idarucizumab or Praxbine? What is that going to be the antidote for? That's actually a monoclonal antibody designed just to grab up the drug and neutralize it. And that was dabigatran, or the brand name, which all of a sudden Pradaxa, is going to be the drug that's used for. Again, that was the monoclonal antibody. You bind up the drug. Remember, Pradaxa was the the factor 2 inhibitor, the direct thrombin inhibitor. Rivaroxaban works on which factor? Remember, there's an X. Apixaban, rivaroxaban. There's another one called edoxaban. Those are all going to be 10A inhibitors, right? So you see the X in the anticoagulant, you're thinking factor 10, okay? But then with heparin, you can actually use protamine sulfate, and that actually will reverse the effects. So actually bind up the heparin and prevent it from interacting with antithrombin 3 anymore. Now, I didn't really get into it, but what you could see is that protamine could be a partial reversal for enoxaparin, but don't really worry about that so much. But just know protamine, and it's a reversal for heparin, okay? All right. Which of the following is a reason for a patient's INR to be supratherapeutic while on warfarin? Could it be the patient accidentally misses doses due to their memory impairment? The patient starts an all-spinach diet? The patient has placed on Bactrim for UTI? Or the patient was started on a CYP2C9 inducer? Now when I say supratherapeutic, what does that mean? Above the range I'm shooting for, right? Which is typically what for warfarin? 2 to 3. Most patients, 2 to 3 when they're on that, okay? If they have a really hypercoagulable state, they have mechanical valve replacement, 2.5 to 3.5. Let's go a little higher than that. What's a normal INR? 1, right? It's an international normalized ratio. So again, you're looking at your patient versus the standardized value. That ratio should be 1 in someone who's not on warfarin. Interesting. Wow. Got you guys. Good on that one. No, all right. So we're looking for the INR to be supratherapeutic, right? So that means above the range you're shooting for, which is set for most patients, like AFib, prevention of clots, 2 to 3 is the range you're shooting for, right? So what would be things that would increase that? Okay, let's look at it. The patient misses doses. No, if they were missing doses, they'd be subtherapeutic. They'd probably be closer to 1, right? If you said 0, I would definitely say, that's not actually right? Because you can't have a 0 INR. It'd be all clot, I guess, at that point. Just like when someone says, like, oh, the patient had GCS is 0. It's like, they can't have 0. 3 is the lowest you get, right? Anyway, patient starts an all-spinach diet. Spinach is high in vitamin K, right? Not potassium. Actually, I have no idea. How much potassium does spinach have? Okay, there you go. So it has both Ks. But vitamin K is one we're concerned with. Phytonadione, remember? If I give a patient vitamin K through their diet, what does that do to those clotting factors? Start to produce again, right? So that would cause clotting factors to start to produce. That gets my patient closer to normal. That drives the INR down or up. Down in those cases, right? So if I said he used to eat spinach all the time, then he stopped, that would cause it to go up in those cases. He has a lack of vitamin K based on this dose of warfarin, right? Okay. CYP2C9 inducer, right? 2C9 is one of the big enzymes that metabolizes warfarin, specifically that S enantiomer that's more potent. An inducer would do what to the half-life of warfarin? It'll go down because I have more enzyme to metabolize it, right? And that does what to my clotting factors being produced? They're going to go up because the warfarin's gone, right? I've metabolized the drug away, so I'm able to use that vitamin K again. So all those cases would drive your INR down in this case. We're asking about the supratherapeutic INR. So if I patient place the patient on Bactrim for UTI, Bactrim does what? Inhibits CYP2C9, which is the big one. What's the other thing? Disrupts the gut flora, right? Remember the vitamin K, it's very important you have your gut flora able to help you to process that so you can absorb that, okay? Again, gut bacteria is a big source of that vitamin K. If you disrupt that, that also can lead INR to go up, okay? Good. Again, I'm sorry if I go over, but again, I think these are all really good points for you guys to study for the weekend. Which of the following medications can help preserve renal function in diabetics? Candesartan, atenolol, quinapril, or furosemide? Remember, go with your gut. It's a skill that you'll develop here, right? I'm trying to rush you, but just go with your gut. Very low stakes here, I guarantee you. Okay, there are actually two correct answers here, right? So remember that both the ACE inhibitors, like quinapril, and then the ARBs, like candesartan, are going to do what for my kidney function? They tend to be kidney protective because they're decreasing Ang2 effect on the efferent arteriole, right? Acutely, they can cause a decrease in function if I had a chronic kidney disease patient, but in the long run, it can help to preserve function, okay? Now, furosemide, what does that do to, like, say, urine output? It should increase it because it's a loop diuretic. Just because I'm increasing urine output does not mean the kidney is actually functioning that much better. Just because I'm producing more urine does not mean that they are actually functioning all that well in the first place. You're just preventing that reabsorption of that salt and that water there. Atenolol, should it have any effect on kidney function? Unlikely, right? So again, that would not be correct in this case here, right? So again, for diabetics, either an ARB or an ACE inhibitor is going to be preferred for those patients, okay? All right. A patient with uncomplicated bacterial conjunctivitis should be treated with which medication? Natamycin, ganciclovir, erythromycin, or moxifloxacin? Uncomplicated bacterial conjunctivitis. All right, so the correct answer here is erythromycin. Natamycin is what? Antifungal. Would not work for bacterial conjunctivitis. Ganciclovir. Antiviral. It's got vir right in the name there. How about moxifloxacin? Now, you would not be wrong to use it. It's just not the most right answer in this case here, right? It would treat a bacterial conjunctivitis. However, what do we reserve the fluoroquinolones for? For pseudomonal coverage, right? Or if you have like contact lens wear or something like that where they're at high risk for that. Corneal ulcerations. Again, that would be a good case where you want to use that, okay? Which of the following could cause cyanide toxicity in patients with liver dysfunction? Ooh, cyanide. We have tamsulosin, nitroprusside, phenoldiprem, or nicardipine. And so I think I took the phenoldiprem thing out because we don't really use that much anymore, so I don't have to think about that one. Sorry if you already answered it. And very low stakes. Stay with me. Stay with me. I know I'm losing you. We're so close. Yeah, I'm doing it. Sorry, guys. Yes, nitroprusside. That was that vasodilator. Remember, it had 5 cyanide molecules with it. So again, there's another drug we gave with it called sodium thiosulfate. That helped the liver to reduce that down and process a little bit better. Nicardipine is another dihydropyridine calcium channel blocker, very good for IV management of hypertension. But nitroprusside is the only one with cyanide here. Good. Let's see. A patient complaining of seasonal conjunctivitis would most benefit from which medication? Cyclosporin, tetrahydrozoline, brinzolamide, or bacitracin. Seasonal conjunctivitis. Again, I'll have brand names on the test, so don't worry too much about that. Cromolyn sodium, not an option. So. Maybe could be used. Yeah. Which illicit drug exposure is often treated with a vasoconstrictor in the eyes? It's usually a little bit of self-therapy. Usually marijuana has a lot of injection of the eye, so oftentimes we use the same drug, tetrahydrozoline. Right, it's a vasoconstrictor, okay? Visine, yeah, it'll be another thing, yep. Anyway, cyclosporin is used for what? Yeah, dry, for like, it's really chronic dry, especially like autoimmune conditions causing that. Brinzolamide is what?
That's the alpha one.
Carbonic anhydrase inhibitor we use for glaucoma. Bacitracin obviously is for bacterial conjunctivitis. Good. Okay. And the last question, which monitoring parameter / drug combination is correct? Is it APTT plus enoxaparin, PT-INR with warfarin, thrombin time with fondaparinux, or anti-factor 10A with dabigatran? Miss Jennifer's ready to go. She's like, I got to get out of here. My goodness, I hope your score's already in. I'm going to let the clock run out on this one if you guys are okay with that. Fantastic. Yes, so PT-INR plus warfarin. Hold on, just wait a second. APTT is used to measure what?
Heparin.
Heparin. APTT and heparin, right? Fondaparinux, I would use what? Anti-factor 10A. Remember, it's only affecting factor 10, so anti-10A. Enoxaparin would be anti-factor 10A. It does not affect APTT reliably, so anti-factor 10A for anything other than heparin out of that group of heparins there, right? And then dabigatran, no monitoring parameters we can use for that, unfortunately. Okay? All right, any questions before I let you go? All right, enjoy EpiBio. I will see y'all later. Thank you.